Hey everyone, my name is Fatima, and in this video, I'll be talking about pulmonary emphysema. Starting with a general overview, emphysema is characterized by the destruction of alveolar air sacs that leads to the permanent dilatation of pulmonary air spaces distal to the terminal bronchioles. This destruction of the alveolar air sacs leads to the loss of elastic recoil and collapse of the airways during exhalation, leading to obstruction and air trapping. It occurs due to an imbalance between proteases and antiproteases. So under normal conditions, if there's inflammation in the lungs, it leads to the release of proteases by neutrophils and macrophages. To counteract this, we have alpha-1 antitrypsin, which neutralizes these proteases. But if there is excessive inflammation or lack of alpha-1 antitrypsin, then this leads to the destruction of alveolar air sacs. So in this histological slide, you can see the normal alveolar air spaces on the right, and these are much smaller compared to those on the left, which are abnormally enlarged with relatively thin septa. Emphysema can be classified into three main types. So you have central asthma emphysema, pan-asthma emphysema, and distal asthma emphysema. The normal asthma basically involves the respiratory bronchiole, the alveolar ducts, and the alveoli. So central asthma emphysema, as the name implies, it's a destruction of the central portion of the asthma. So mostly involving the respiratory bronchioles, sparing the distal alveoli. This usually affects the upper lobes of the lungs, and it's the most common form of emphysema, most commonly seen in smokers. In pan-asthma emphysema, you have complete destruction of the asthma. So the respiratory bronchioles and the alveoli are affected. It usually affects the lower lobes of the lungs, and this is a bit more rare. It's associated with alpha-1 antitrypsin deficiency. In distal asthma emphysema, you have the proximal portion of the asthma, which is normal, but the distal part, which is being affected, it's more prominent adjacent to the pleura, where it can present as bullous emphysema with large bullae, which are prone to rupture and can lead to pneumothorax. The risk factors are smoking, which is the most common cause, and alpha-1 antitrypsin deficiency, which is not that common. Pathogenesis. In the case of smoking, you have some noxious stimuli, which triggers the inflammatory process. So you have release of proteases, again, for example, elastases, which causes destruction of the elastic tissue. And this loss of elastic tissue then causes basically the sequelae. So you have enlargement of the air spaces, decreased elastic recoil, increased compliance of the lung. You have expiratory airway collapse and obstruction, air trapping, decreased ventilation because of the air trapping, and decreased gas exchange, which leads to hypoxemia and hypercapnia. For alpha-1 antitrypsin deficiency, you have the lack of antiproteases, which leaves the air sacs vulnerable to protease-mediated damage. It usually results in pan-asthma emphysema, like we talked about, with the lower lobes being affected. You can also have liver cirrhosis because the alpha-1 antitrypsin deficiency can be due to a misfolding of the mutated protein, which would accumulate in the endoplasmic reticulum of the hepatocytes, causing liver damage. You can see this in biopsy as pink PS positive globules in the hepatocytes. The disease severity is basically based on the degree of alpha-1 antitrypsin deficiency. So PIM is a normal allele and PIZ is the mutated allele, which results in low levels of circulating alpha-1 antitrypsin. For heterozygotes, PIMZ, they're usually asymptomatic, but they have a high risk for emphysema with smoking. But homozygotes, so PIZZ, they have a very significant risk for pan-asthma emphysema and cirrhosis. So in this picture, you can see the classifications. So in the first one, you have central asthma emphysema, mostly being the respiratory bronchioles, which are affected. In pan-asthma emphysema, you have the entire asthma being affected. And in distal asthma emphysema, you can see it's more prominent in the subpleural region, with these bullae being prone to rupture and causing pneumothorax, like I mentioned earlier. The clinical features include dyspnea, cough with minimal sputum, pursed lip breathing. We also known as we call these people as pink puffers. The patients basically breathes out slowly through pursed lips. This causes a bit of back pressure, which prevents the bronchial collapse during the last phase of expiration. You can also see hypoxemia due to destruction of the capillaries in the alveolar air sacs. Weight loss, And later complications involve barrel chest, which is increased anterior posterior diameter of the chest, and cor pulmonale. Here are the references that I used, and with that, we come to the end of this video.